Welcome to the deep dive. Today we're really digging into Alzheimer's disease, AD. It's the most common reason people develop dementia in the developed world. And if you've ever felt a bit lost trying to grasp the stages or the underlying problems in the brain or even just the treatments, well, this is for you. We're going to try and give you a clear roadmap, our goal. Walk you through what's actually happening physically, the key steps for diagnosis, making sure it's not something else, then the 4 clinical stages, and how management changes for each one.
Okay, so to really get it, you need to understand what's physically breaking down in the brain. We often talk about two main things you can actually see. First, there are these extracellular deposits, clumps of stuff outside the neurons called amyloid plaques.
Right, those are the ones everyone talks about now, with the new drugs targeting them.
Exactly. And then second, inside the neurons, you get these abnormal buildups of another protein, tau protein, forming what we call neurofibrillary tangles. They basically clog things up internally. But there's a third piece, maybe less visible, but really critical, especially for the treatments we've used for years.
Okay.
It's about the brain's chemistry, specifically the loss of certain nerve pathways. We see a die-off of what are called cholinergic neurons, particularly in a spot called the nucleus basalis of Meinert.
Huh.
And when these neurons die, the level of a key neurotransmitter, acetylcholine, drops across the brain, especially the cortex.
Okay, that clicks. So if the neurons using acetylcholine are dying off and there's less of the chemical messenger, that's where some treatments step in.
Precisely. That acetylcholine deficit is the whole reason behind the older medications, the symptomatic ones. The idea is if we can boost the signal from the acetylcholine that's left, we can sort of temporarily improve how the brain cells talk to each other.
Got it. So plaques, tangles, and this cholinergic loss, those are the big 3 driving the symptoms.
Those are the core pathological features, yes.
So if that's what's happening inside, how does it first show up? What does a patient or their family typically notice?
Well, the story you usually hear is about a slow decline, right? It's gradual, not like a sudden event. But the memory loss is specific, isn't it? It's episodic memory. Forgetting like specific things that happened, appointments where they put something down just moments ago, maybe birthdays or recent conversations, personal events.
Yeah, and that forgetfulness, it starts to bleed into actual difficulty doing things. They might struggle with, say, visual tasks, like navigating even familiar places or following steps in a sequence, and then performing normal daily activities starts to get harder. Managing finances, planning meals, even basic self-care eventually.
And we should probably mention risk factors here too, like the apolipoprotein E4 allele.
Absolutely. Being a carrier of the APOE4 allele is a major genetic risk factor. It definitely increases our suspicion when we see these kinds of symptoms emerge. Okay, that's important context. But before jumping to an AD diagnosis, you mentioned it's crucial to rule out other possibilities. What's the essential workup look like?
Right, first things first, a good history, a physical exam, and then a standardized cognitive screening test like the MoCA, maybe the MMSE. But the goal isn't just confirming impairment, it's finding anything reversible.
Which leads us to blood tests. The must-do list.
Exactly. You absolutely have to check vitamin B12 and TSH levels. B12 deficiency, hypothyroidism, both are common, both can cause cognitive issues, and both are often treatable.
Makes sense.
And critically include a depression screen. Depression can look a lot like early dementia or happen alongside it. You need to tease that out.
And beyond blood work, what about looking at the brain structure itself or other body systems?
Correct. Imaging is essential. A CT or MRI scan. You're looking for structural causes. A tumor, old bleeds, evidence of strokes, things like that. And you have to carefully review their history for anything else that might be affecting cognition. Certain medications, especially anticholinergics, are notorious. Excessive alcohol use, or other conditions like hepatic encephalopathy if their liver isn't working well.
Okay.
So if those initial checks, B12, TSH, the brain scan are basically normal, but the cognitive screen shows a problem, then your confidence in a primary neurodegenerative cause like AD goes way up.
That really lays the groundwork. Now, what about the physical exam itself? You said early on it might be normal, but later some pretty unusual signs can appear, these frontal release signs.
Yes, this is fascinating, actually. These signs tell us about damage happening in the frontal lobes. Frontal release signs are basically primitive reflexes, things babies have that normally disappear as the brain matures, but they can reappear when the frontal lobe loses its usual inhibitory control.
Wait, seriously, so in later AD you see reflexes that are almost infant-like. That's quite striking.
It really is. For instance, the grasp reflex. If you place your finger in the patient's palm, They might reflexively grab onto it without meaning to.
Wow.
Or the palmomental reflex, if you stroke the palm near the thumb, you might see their chin muscle twitch involuntarily on the same side. These aren't always there,
Yeah.
but when you see them, along with perhaps some rigidity or overly brisk reflexes later on, it points towards that frontal system involvement.
Okay, so the clinical picture is strong. We've ruled out the mimics. Imaging might show some atrophy maybe in the hippocampus or temporal lobes. How do we get closer to confirming it as AD, especially with newer tech?
Well, confirmation ideally means finding direct evidence of the AD pathology. The established non-invasive way is an amyloid PET scan. It uses a tracer that binds to amyloid plaques, so they literally light up on the scan.
Right.
But things are moving quickly towards less invasive biomarker tests using cerebrospinal fluid, CSF,
Sure.
or even blood plasma.
Okay, like,
In CSF, we can measure the ratio of two amyloid peptides, amyloid-beta 42 to 40. An abnormal ratio points strongly to AD pathology. And even more exciting, potentially, are plasma tests. Measuring phosphorylated tau-217 or k-tau-217 in the blood looks very promising.
phosphorylated tau-217, what exactly is that measuring? Is it a piece of the tangle?
It's a specific form of the tau protein, one that's been chemically modified phosphorylated at a particular spot, number 217. High levels of this specific form in the blood seem to be a very accurate indicator of AD pathology in the brain, even early on. It's potentially revolutionary for screening.
The blood tests, that would be huge. But that brings up a really practical point. If these amazing tests exist, why are most diagnoses still based mainly on clinical evaluation?
Yeah, that's the reality gap right now, access. These biomarker tests, the PET scans, the CSF assays, the newer plasma tests, they're powerful, yes, but they're not widely available everywhere. They can be expensive, insurance coverage is still evolving.
Ah,
So for the average person seeing their doctor today, the diagnosis of Alzheimer's still heavily relies on that careful clinical assessment. The history, tracking the functional decline, the cognitive testing, and meticulously ruling out everything else.
that's such important context. Okay, let's shift gears to staging, because treatment really depends on where the patient is in terms of their functional ability. Stage 1, mild cognitive impairment, or MCI.
Right, and the key thing about MCI is that it's not dementia yet. The person has noticeable cognitive issues, memory problems, maybe difficulty planning, but they can still manage their daily life independently.
Okay.
They might be slower, need more reminders, use more strategies, but they haven't lost that fundamental independence.
And you mentioned earlier MCI doesn't automatically mean someone will get AD, correct?
That's right. MCI is kind of a symptom complex. It can have different underlying causes. Some people with MCI stay stable for years. Some might even revert to normal cognition, though many, especially if amyloid is present, do progress.
So if someone's at the MCI stage, what's the approach?
Initially, the focus is really on non-drug approaches, lifestyle stuff. Regular physical exercise, maintaining a healthy diet, staying mentally and socially active, avoiding being too sedentary. These things are important. But this is also the stage where if amyloid pathology is confirmed with biomarkers, then they might be a candidate for the newer anti-amyloid-beta monoclonal antibodies like lecanemab.
And why are those drugs considered such a potential game changer compared to the older ones?
Because they're the only things we have right now that are actually disease-modifying. They target the underlying pathology. They physically clear amyloid plaques from the brain. The older drugs just manage symptoms.
But these new drugs have that significant safety concern, ARIA. What exactly is that, and why the need for close monitoring?
ARIA stands for amyloid-related imaging abnormalities. It usually shows up on MRI scans as either brain swelling, called edema, or small brain bleeds, microhemorrhages.
That sounds serious.
It can be. That's why patients on these therapies need regular MRI monitoring, especially early on. And it means these drugs are definitely not suitable for everyone, particularly people already at high risk for brain bleeds, like those on anticoagulant medications. It's a real risk-benefit calculation.
Understood. Okay, so now the person crosses a line functionally. They move from MCI into mild Alzheimer's disease. What's the key change that marks this transition into actual dementia?
The defining change is the loss of independence in more complex activities. So, in mild AD, the person is typically still okay with basic activities of daily living. We call them BDLs, things like feeding themselves, dressing, basic hygiene.
Right.
But they now need help with, or can no longer manage, the instrumental activities of daily living IADLs. These are the more complex tasks needed to live independently in the community.
Yes.
Using the phone effectively, managing shopping, preparing meals, handling finances, taking medications correctly. Difficulty with these IADLs is what signals the shift from MCI to mild dementia.
And once they're in mild AD, how does management change? What drugs come into play?
This is typically where we introduce the acetylcholinesterase inhibitors. Drugs like donepezil, galantamine, rivastigmine.
And these work by boosting that acetylcholine level we talked about earlier.
Exactly. They block the enzyme that breaks down acetylcholine, so there's more of it available for signaling between the remaining neurons.
But just to reiterate, these help symptoms, they don't stop the disease itself.
Correct. They can provide a modest temporary benefit in cognitive function and daily activities for some people. They don't alter the underlying progression. And importantly, someone at this mild AD stage might also still be eligible for those anti-amyloid therapies if they meet the criteria.
Okay. Let's move to the later stages then, moderate and severe AD.
Right. By the time someone reaches moderate AD, the functional decline is more pronounced. Now, they need help even with those basic activities, maybe assistance with dressing, bathing, toileting.
And the medication strategy changes again.
Yes. For moderate AD, we usually continue the acetylcholinesterase inhibitor, PLUSS. We add another medication called memantine.
Memantine. How does that one work? It's different from the first type.
It is different. Memantine is an NMDA receptor antagonist. It works on a different neurotransmitter system involving glutamate. The idea is that in AD, there can be excessive glutamate activity, which is toxic to neurons, and memantine helps to sort of dampen that down, offering a different kind of neuroprotection or symptomatic help.
Got it. And a key point here. Once someone reaches moderate AD, those anti-amyloid drugs are generally off the table, right?
That's currently the case, yes.
Yeah.
The trial's focused on earlier stages,
Yeah.
so eligibility is typically limited to MCI due to AD or mild AD dementia. Then finally, you have severe AD. At this point, the person is essentially completely dependent on others for all aspects of care, basic activities included.
And treatment, still the same combo.
We often continue both the cholinesterase inhibitor and memantine. However, especially in very severe stages, there's a real clinical discussion to be had about continuing the cholinesterase inhibitors.
Why is that?
Because, frankly, so many of those acetylcholine-producing neurons have been lost by this stage that the drug might not be providing much benefit anymore. You have to weigh the potential side effects against any remaining efficacy. It becomes a very individual decision.
Wow. Okay. That maps out the progression and the corresponding strategies quite clearly. We've gone from the molecular level right through to profound functional dependence. Let's try to quickly synthesize the main points for someone listening. So, first step, if AD is suspected, rule out the mimics. Check B12, TSH, get imaging, look for depression, problematic meds, other conditions.
That's job one, diligence up front.
Then, if suspicion remains high, confirmation can come from clinical signs, those frontal release reflexes later on, for example, or ideally through biomarkers like an amyloid PE scan or maybe CSF tests or these emerging blood tests like pTau217.
Right, looking for that direct biological evidence if possible.
And finally, it's the person's functional ability that determines the stage MCI, mild, moderate, or severe, and that stage dictates the treatment plan. Lifestyle changes early on, then adding symptomatic drugs like cholinesterase inhibitors, and potentially memantine, and considering those anti-amyloid therapies only in the early biomarker-positive stages, weighing the ARIA risk carefully.
That captures the current approach quite well. But here's something maybe to think about as we wrap up. We've highlighted this gap, right? The fact that diagnosis for most people still rests heavily on clinical judgment because access to those definitive biomarkers is limited.
Yeah.
So, looking ahead, what does that tension mean? As the science for biological confirmation gets better and better, but access remains uneven, how does that impact equity? How do we ensure that advances in early diagnosis and potential early treatments actually reach the average patient, not just those near specialized centers? That's a really critical question, I think, for the future of AD care that you, the listener, might want to keep exploring.